I am going to talk something about diagnosing food allergy, and I was asked to comment on the NIAID Guidelines, which were published excuse me, towards the end of 2010, and then also where are we going with component testing with respect to food. So these are my disclosures, none of which will really be relevant this evening. So just to give you an idea, for those of you who don't know about the NIAID Guidelines, this was basically a group, or a number of groups, 30 different professional organizations, federal agencies, and advocacy groups that were brought together at this time by FAN as well as NIAID and the American Academy. Independent literature search was done by the RAND Corporation of all articles related to food allergy, and this involved over 12,500 citations. So this RAND Corporation did this systematic review, provided us with data, and the guidelines were based off of evidence that was derived from this review. In order to write the guidelines, there were 5 expert panels put together. These are the topics of the various panels, and then once these guidelines were put together, they were then reviewed by a coordinating committee, and then through the government agencies, you always have to post these for comment. So they were up for comment for about 6 months, and then we came back, responded to the comments, and then these were the final guidelines. So what I want to do is just focus on the ones relevant to diagnosis. And the first, which shouldn't be too surprising to people in this room, is that the expert panel recommended that the medical history could in fact be quite valuable. And one of the things I want to show you is when we're interpreting our laboratory studies, and especially when you're interpreting the quantitative values, it really is important to know how likely you think it is that the history supports or does not support a diagnosis of food allergy. But the other thing the panel said was that history alone, regardless of how strong, by itself could not be considered diagnostic for food allergy. The physical exam may be useful, there may be some supporting data there, but again, there's nothing there that will in any way give you the absolute diagnosis of food allergy. So then the literature was reviewed with respect to the skin prick test. Again, the expert panel, based on that evidence, said that the skin test could be useful in helping to identify foods that would be potential causes of food allergy. But again, a skin test alone cannot be considered diagnostic of a food allergy. Basically, what it was, the conclusion after this review was that the skin test simply tells you of the presence of IgE antibodies on local mast cells. It did suggest, though, that the concept of wheal size or increasing wheal diameter reflecting likelihood of reactivity was probably clinically relevant. And this comes largely from some of the initial work of Richard Sporek that was back over 13 years ago, where they were looking at a large group of children with milk allergy. So they basically looked at the outcome of 120 oral milk challenges in which 37% of the group did have a positive challenge. And what Dr. Sporek and his group noted was that once these children had mean wheal diameters greater than 8 millimeters, that all of them seemed to react to the food. And this then led to the concept, much like we'll talk about with quantitative IgE, that the larger the skin test size, the more likely it was that the patient was going to react. And then they looked at the 3 major allergens in children, milk, egg, and peanut, with the mean wheal diameters that are in their series 95% predictive, being around 8 millimeters. Now the problem with this is that everybody does skin tests a little differently. People buy different reagents. The reagents are not standardized. They have different methods that they do the prick skin test. There are different devices. There's differences depending on whether you do it on the arm or the back. So there are a lot of variations that come about from doing it this way. Now, you could validate it within your own practice, but or you can get some concept that this value will be useful, but you do have to remember there's a lot of variation. The other thing to think about is this study by Pukar et al., where they looked at 140 children for possible peanut allergy. And in this group, there were 64 children that had a positive skin test for peanut. All these children underwent oral food challenges. 18 of the 64 ended up having a positive food challenge. So the open circles are those individuals who had a negative challenge. The closed circles are those who had the positive. What they noted here was that all children who had positive challenges had a prick skin test, mean wheel diameter that was at least 5 millimeters. However, contrary to what Dr. Sporek had suggested, if you look at those individuals with mean wheel diameters 8 millimeters or greater, 12 of 23 had negative food challenges. So suggesting that in their hands, the skin test size, at least of 8 millimeters, was not that reliable. And when you look at the open circles and closed circles, you'll see there are some children there that have fairly large mean wheel diameters that still had a negative food challenge. So evidence here that with the skin test alone, unless you have a very definitive history, it certainly cannot be considered diagnostic. Then looking at the studies related to the use of intradermal testing, I think this was put in for Dr. Platts-Mills, that intradermal testing should not be done. They also looked at the use of total IgE, and based on what was in the literature, there's no evidence that using total IgE in your diagnostic evaluation is of value. Based on, again, on the literature, however, the committee did recognize that specific IgE, especially quantitative specific IgE, might be helpful, and that, like most other tests, however, in isolation, without appropriate history, should not be considered diagnostic. The other thing that came out in this review was the fact that the newer methods of quantitating IgE are probably just as sensitive as the prick skin test. And this is something that for many, many years, at least when I started, it was always said that the in vitro tests were not as sensitive. Based on the current literature, that's not felt to be true. As you know, a number of years ago, we published an article looking at the concept of quantity of specific IgE to certain foods being associated with the likelihood of developing clinical symptoms. And here what you see with egg, these are both retrospective and prospective study looking at the probability based on the amount of IgE. So with someone with egg allergy at a level of about 7 kilounits, it's 95% likely that they would have a reaction. And then similarly with cow's milk, fish, and peanut. Now, one of the things you probably are aware of is that there are a number of different laboratories that have quantitative tests. And oftentimes, unfortunately, in the clinical situation, the insurance company dictates to us which lab you're going to send it to. But you need to be aware of which laboratory is running your study, because there have been 3 studies now listed down here that have looked at samples, the same sample being done in the different laboratories, and showing that the values were not necessarily the same. So most of the work that we've done, we have done with the UNICAP system, because that was the first available, and that was the first one that we have gone through and done validation for our studies. The other thing, though, is like any test, no test is perfect. And this is a study done by the Berlin group with Kirsten Beyer and her colleagues, looking at 62 patients who had suspected peanut allergy. Specific IgE levels were obtained on all these patients. 28 then had a negative peanut challenge. 34 ended up having a positive peanut challenge. When you look at this, what you see is that 7 individuals who had levels above 15 kilounits per liter which is the one that we consider to be 95% predictive, had negative peanut challenges. Now, it's likely, and it wasn't looked at in this study, but birch pollen is a problem in this area, and as I'll show you, this can give you a higher level of total peanut that is not necessarily related to the protein that causes the problem. And then the other thing to remember is with lower values, and a lower value in no way means somebody is not going to be reactive, and it is necessary to do a food challenge to ensure that they can tolerate it, because as you see here, there are a number of individuals with lower levels that still were quite reactive, and this tends to be more true in older patients. So what is the role then for component testing? As you know, there are a number of proteins within, especially things like the peanut and tree nuts, wheat, that do cross-react with pollens. And these can, as I said, make it appear that somebody has a higher level to a peanut or a tree nut than you might consider to be diagnostic for reactivity. So what we know now is that there are proteins, component proteins such as ARH2, which much more closely relates to the likelihood of reactivity than some of the other proteins such as ARH8, which is a BETV1 related protein. So in our area where we have a lot of birch pollen in the Northeast, it's not uncommon to have somebody come in, a child, say 9 or 10 years old or early in their teens, who suddenly now is having an itchy mouth and itchy lips and maybe swollen lips when they eat peanut, and immediately the family panics and thinks that they're now a peanut allergic individual. And what we're finding is there are a fair number of these individuals who in fact have fairly high ARH8 levels. They may have a level of total peanut, or the F13 or the whole peanut, that's 17 to low 20s. And yet when you look at it, there's no ARH2, it's all ARH8. Also, hazelnut, another problem with the BETV1, CORE1 can be falsely give you the idea that they're going to be reactive when in fact, they would likely only get some oral symptoms, whereas CORE9 is much more likely to lead to systemic reaction. Similarly with soy, we're seeing individuals who are positive to GlyM5 and GlyM6 who may be able to eat soy in low quantities in food, but when they start eating these high-protein power bars or high-protein, soy protein energy drinks, now start to get symptoms, whereas otherwise we don't tend to see the systemic reaction. Also, there's some indication that some of the wheat components may be helpful, but I think this still has to be worked out. Now, I think the best study out so far looking at this is Carsten Binsleb Jensen's study from Denmark, looking at a group of 123 individuals evaluated for peanut allergy. They showed that all individuals who had an ARH2 IgE level in excess of 1.63 did have a positive peanut challenge. So if you have an individual who has a level of peanut-specific IgE less than 15, what we're often doing now is looking at the ARH2 component to see what the level is. If it is in excess of this number, then we do consider with a sufficient history that this person is in fact peanut allergic. As Carsten's study showed, however, again, there are individuals with lower levels who are going to also react. Jay Lieberman at our place has also been looking at some individuals, and we found in individuals who have a strongly suspected history of reacting with a positive to ARH2 was in fact on challenge most likely to be reactive. As you know, the total IgEs to various fruits and hazelnut do not correlate very well with clinical reactivity, but again, we can get some information by looking at the BETV1 homologs, which typically will correlate with the oral allergy syndrome, as opposed to some of the other proteins, such as the lipid transfer proteins, where we see, especially in the Mediterranean area, a much higher likelihood of individuals reacting when they have evidence of IgE antibody to some of these proteins. And then in our study and others looking at CoRA9 for hazelnut, individuals who have significant levels of IgE to CoRA9 as opposed to CoRA1 are going to be very likely to be clinically reactive. The other thing to remember is the cross-reactivity. We often see or get histories of people having cross-reactivity to various species of fish and tree nuts. This is just to show you with fish, it's not been as well worked out, but there's definitely cross-reactivity between a number of the different species. Similarly with tree nuts, but many of the other things, such as the legumes, we see very low rates of cross-reactivity. So there's no necessity of telling a patient with peanut allergy that they must avoid all legumes. Now, when we follow patients and try to decide when they're going to outgrow it, as you know, only about 20% of individuals with peanut allergy will outgrow it. And in our experience, young children who have levels that never exceed 5 kilounits per liter are more likely to be in that group that will outgrow it. And once they get above that level, it gets less and less likely. But we will watch these individuals, and when they fall below 2 kilounits per liter, we have a pretty good negative challenge rate on this population, certainly more than 50% being non-reactive. With egg and milk, similarly, when they get into the lower range, we see that they have less likelihood. Now, I just want to propose this one concept of looking at likelihood ratios and prior probability based on your clinical history. So the likelihood ratio basically is looking at the sensitivity over 1 minus the specificity. And the sensitivity and the specificity of the assays are pretty well determined. Basically what you do, and you can primarily do this more or less in your head, but basically you need to get an estimate of how likely you think it is that this individual is going to be reactive before you interpret your test. And then by looking at this, you can make a quick decision as to the likelihood that these individuals will be reacting. So just to give you an example of this, you have a 5-year-old with 4 acute episodes of urticaria and angioedema after ingesting egg. His last episode occurred 1 week before your evaluation. His CAP IgE, though, is less than 0.35. So if based on the history, you would say it's highly likely that this individual would be reactive, but given that very low IgE on the CAP, or on the specific IgE, you can't really say with certainty that this individual is going to be reactive. So the best you could say is that there's about a 70% chance, even though the history is very strong, but with that low level, about a 70% chance that this individual would be reactive. So you would have to conclude probably egg allergic, but really not certain, and you may have to do a food challenge. On the other hand, if you have a 5-year-old with the acute episode of urticaria angioedema to egg, again, last episode a week ago, and now you look at it and he has a 8-millimeter wheal, this is much more suggestive that this child is reactive. Again, you have that very high probability based on your pre-test analysis, and in this case, you would conclude, even though the IgE test was quite low, that this child is really likely to be clinically reactive and probably would not go on to a food challenge. Another one, and this is one that we do see, a 15-year-old with the oral itchiness and throat tightness after eating a candy that has some peanut butter in the center. Skin test was 10-millimeter wheal, peanut IgE of 17 kilounits. But this is the first time in a 15-year-old. So you would have to say that the pretest probability does not sound typical of somebody with systemic reactivity to peanut. So even though you have tests that are somewhat more suggestive, with that questionable history, you would probably have to conclude it's only about 60% likely that this child would be reactive. So this is a great place where you may want to look at a component assay. So we now, again, look at this. Here, the RH2 is less than 0.35. The RH8 turned out to be 23 kilounits. So given that, knowing that it's the BETV1 related protein, it's most likely this individual simply has oral allergy syndrome and is not going to have systemic reaction when ingesting peanut. So the BETV1 related oral allergy syndrome. So just to finish up, again, looking at the remainder of the testing armamentarium, the expert panel did recommend oral food challenges for making the diagnosis, concluded on the evidence that the double-blind challenge was the gold standard, but indicated that the single-blind challenge and the open food challenge were acceptable methods of making a conclusive diagnosis in a couple given situations. One, if the food challenge elicited a negative challenge, because a negative challenge is negative, or in the case of a positive challenge, if there were objective symptoms that correlated with the history. So you need somebody who has the history of developing some urticaria, maybe rhinitis, and when they come in and get challenged, these are the symptoms they develop, not somebody who has one quick episode of vomiting, which may have been more related to the fact they didn't like the particular food. So in making a diagnosis of food allergy, taking into account what we know from the literature based on the NIAID guidelines, a detailed medical history is really critical to establish a pretest probability of somebody having a reaction. The prick skin test will give you a quick answer as to whether or not IgE is present. It may be useful in helping you decide. Getting quantitative specific IgE antibody, again, will add more weight to the evidence on the likelihood that they would be reactive. And then there are foods at this point in time where the components may be very useful in helping you determine whether or not they're reactive. Hopefully, as more studies are done, we will have more help from some of these other component tests that are being looked at. Thank you.